Welcome, everyone, to the Center for Global Development virtual version. My name is Amanda Glassman. I'm Executive Vice President and a Senior Fellow working on global health here at the center. And I'm really excited today to host two of the co-authors of a really interesting new paper that looks at how the universal health coverage and global health security agendas intersect and don't, and what that might mean for the way that we finance and cooperate on global health going forward. So we'll start off with Negozi, who's a senior scholar at the O'Neill Institute at Georgetown University, as well as an associate fellow at Chatham House, and Arush Lal, who's the board vice chair of Women in Global Health, and is a candidate for a PhD at the London School of Economics and Political Science. They'll present the findings of their paper, and then we'll turn to three discussants. It will be myself, Dr. Priscilla Bekwe from the Nigeria CDC, and Kelly Saldana, who's the Director of Health Systems at the U.S. Agency for International Development. I don't think we could be speaking about a more timely topic as we consider what is happening in the COVID-19 response and how we should plan to work differently in the future. So turning it over to you, Dr. Negozi, go ahead.
Thank you very much, Amanda. I'm really delighted to have the opportunity to present before all of you today. Today, we're going to be speaking about a topic that is unfortunately very familiar by now, but in the difficult times that we're in and the global devastation and disruption that not only COVID has presented, but also the positive disruptions of decolonial approaches, racial justice, and equitable partnerships. Hopefully this gives us an opportunity to do more than just continue this discussion. I'm really hoping that after this and other voices that are calling for the unification of global health security and universal health coverage, I hope that we'll see a more concerted action towards achieving it. Arush, could you please do the next slide? Thank you. So I'm excited that the work that Arush and I and our other co-authors did has brought us to you today. I'll start by grounding us in the policies and systems that we are referring to when we talk about systemic misalignment in health systems and fragmentation in aid. Next slide, please. So all epidemics arise from weak health systems. I think when Dr. Quick said this, I think in 2015, a lot of us believe this, but now all of us are seeing this. Next slide, please, Arush. But for many of us, the disjointedness between universal health coverage and global health security, it's been more than a policy analysis or an assessment. It happened when we heard about the horrific numbers of more than 11,000 people who lost their lives across 3 countries in West Africa during the West African Ebola epidemic. But then we have learned of several other striking figures. One paper estimated that from 2014 to 2015, there was an estimated 50% reduction in access to healthcare services in the 3 countries, which resulted in an additional estimate of 6,200 deaths in Guinea, 1,500 deaths in Liberia, and 2,800 deaths in Sierra Leone. And this was just for malaria, TB, and HIV. Now, these figures testify that Ebola was not just a security issue to those who were directly infected by the virus, but it was a security issue and an individual issue to the even greater number of people who could not access the overburdened health systems for other endemic diseases or chronic diseases. Yes, so this has led to many academic analyses about how international health regulations and health system strengthening frameworks have resulted in the divergence of global health security and universal health coverage. So Dr. Claire Wenham and her co-authors and Dr. David Heyman and his, they really summed up that these 2 approaches provide a tension between the risk of the individual and the collective. After Ebola, at London School of Hygiene and Tropical Medicine, we held a consultative meeting, one of many, that was to really hear from the individuals that were involved in the Ebola response, from the country level, the multilateral organizations, as well as bilateral donors and others that could highlight the consequence of this division and how it was being handled at higher levels and with policymakers in the 3 countries. And it resulted in a 2018 paper where myself and my co-authors argued that the tension between this individual and collective risk was unnecessary. And we proposed a unified health system under universal health coverage with complementary global health security functions. And before I go into, just a little bit of what we recommended, that paper really is what Arush built on, and the co-authors built on, and Arush will present. But it really helps us to, I think, to stop here and then kind of go into the foundational policies of global health security and UHC before we go forward. So next slide, please, Arush. Thank you. Okay, apologies. Right, so here you see that we have, the 2 policies that really that drive global health security and as well as universal health coverage. So the International Health Regulations was established to boost global commitment to reducing the likelihood of outbreaks. This is the WHO framework. Accordingly, global health security policies align to the international health regulations and reinforce national health systems, ensuring that they have the functions to prevent, detect, and rapidly respond to public health risk and emergencies of international concern. Similarly, health system strengthening, which is a model that is not always aligned to UHC, but has many of the same features, it's really based on these building blocks of what a health system should have. And in the middle, you can see kind of the pathways to achieving the goals of a health system. Next slide, please. But you can see in the health system strengthening, it's really about ensuring that there's universal access to quality health services and really protection from financial hardship for the individual if you look at the different components of the building blocks that make up UHC. But the question is there too much emphasis placed on strengthening curative services? Where would emergency preparedness, such as surveillance and diagnostics, where would that be included in this? Where is the area in health system strengthening? Where's the place for population health services? Next slide, please. Also with global health security, you can see that these are the different core areas of the IHR. And there's been much discussion about the absence of curative services. There's no patient management or mention of clinical surge capacity in these 8 core capacities of IHR. And it simply doesn't address the treatment of patients up to recovery and effective containment and resolution of outbreaks and epidemics. So this framework really also provides an incomplete definition of what the health system function is during outbreaks or emergencies. Next slide, please. So these frames and the positions that funders of development and donors of aid have taken has really created political and funding divisions. And much of it has been illustrated in how countries that have embraced either of these policies have been impacted by COVID-19. And Arush will shortly present some case studies that we talk about in our paper. Next slide, please. So after SARS, Ebola, H1N1, Zika, and the many outbreaks that have been happening before COVID-19, global health security somewhat evolved into how to protect rich countries. And so there's a lot of money out there for defense, especially in the US. And so globally, we have funded and perpetuated a flawed divide by investing in global health security over UHC in most cases, often ending up with one neglected system and one unsustainable system. So instead of justifying why these should be unified, I'll just go straight into, that there are some areas that exist that are very synergistic. This is adapted from Dr. Wenham's paper, but there are areas like, real-time surveillance, as well as health information systems, which is, categorically under health system strengthening, that should be harmonized. And if you talk to, surveillance officers and National Public Health Institutes, this is something that they're already working towards. But this also needs to be funded and not in these separate buckets of either GHS, HSS, or UHC. So in this slide, you can just see there's other areas that also we're not even really capturing when we think about UHC, and even not capturing that well when we think about preparedness, when we looking at leadership and governance and health workforce. I think that's something that in COVID-19 we're able to see. Without these two tenets in place, global health security cannot be achieved, and universal health coverage will be very fragmented. So I will stop here and pass it on to Arush to discuss our paper and some more examples of how these policies and systems played out in COVID-19. Thank you.
Thanks so much, Negozi. Yeah, I mean, I think what Negozi did is actually really important as well for not just setting the context, but also looking at where these overlaps exist and what some of the downsides can be. And so that was the real imperative of our paper, was to build on that existing body of work that was beginning to emerge on synergies, and looking at how that has played out in at least the beginning several months of COVID-19. So we compared examples of health systems that were either heavily dominated by global health security approaches, heavily dominated by UHC approaches, or those really nice ones that kind of found or attempted to find that sweet spot in between both of those. So I think maybe it's good to first start with kind of global health security dominated health systems. A great example there is the United States of America. It's a country that many might remember actually was regarded, placed at #1 in terms of pandemic preparedness, as like #1 country ranked for ability to respond effectively to something like COVID. And we all know that that was not the case. The country is characterized by really strong laboratories, good pharmaceutical and technology industry, public health institutes, but notably a big lack of universal health coverage or publicly accessible health systems. We saw in COVID-19, it led to fragmented state and federal coordination. I think there's a really interesting case to be made as well about tying health insurance in the US to employment. And in a pandemic where many people lost their jobs in record numbers, that really exacerbated outcomes. And we also saw hesitancy and distrust of public health services. And this is something that we see a lot that can be sometimes remedied by more UHC systems, is when you are kind of lacking those accessible, affordable health services provided by the government and the public sector, there's often this mistrust to adhere to public health guidance because that relationship is not there. Nigeria has kind of a similar story, but in different ways. They have a really leading CDC institute, and we'll hear a colleague later on from that kind of explain more of that context, but also arguably some of the strongest public health infrastructure on the African continent, with really good experience managing Ebola, HIV, polio, and other epidemics. But similar story, a lack of universal health coverage and publicly financed health systems found COVID-19 leading to inadequate critical care and intensive care units, a lack of accessible health facilities. There was also really poor protection for health workers with inadequate personal protective equipment and masks, and that actually led to a lot of strikes, which further kind of exacerbates these issues. And also an issue that was not unique to Nigeria, but is a lesson as well, is the need to support vulnerable daily wage workers in micro communities that need ability to kind of that protection to access health services. Critically, after the publishing of our paper, there have been some improvements, and we're seeing some progress on UHC kind of pivots. I think most notably, the Biden administration published its US COVID-19 strategy. And I think I've seen some of the strongest language for more of these kind of UHC components, like childcare support, education support, a surging of health workers at the community level, and also really, really critically, free vaccines. And that's something that is kind of a clear lesson right there. I mean, if that's important enough for COVID, why isn't free treatments, or at least affordable treatments, an urgent priority for the administration moving forward? And we see kind of this language around more push for primary healthcare infrastructure, low-income support, integrated data systems that Negozi mentioned is kind of this, an important element across both. We're seeing these elements increasingly called for in communities. On the flip side, we have systems that are dominated by more universal health coverage approaches. The United Kingdom is a great example here, with the National Health Service having comprehensive unit UHC, and the history of the NHS has yielded a high degree of trust in health services, which I think in a way almost lulled a sense of complacency that the system is going to be able to cope. But in the end, we saw that a lack of experience in dealing with outbreaks more recently like this, and maybe perhaps this reliance on the existing health system led to really poor risk communication with mixed messaging, delayed testing and contact tracing. And I think, and also important for this conversation, fragmented financing, is chronic cuts to the public health service. I mean, while the NHS has received a lot of support, there's no question that it's lost a lot of funding, especially in public health infrastructure and staffing in recent years. And that's probably an important lesson on the global health security side of things. Italy, there's an interesting case study looking at the state of Lombardy in particular, which is actually one of the wealthiest regions in Europe, which has a very high degree of UHC for all individuals, and communities that are characterized by really high income contexts. And I think that was also kind of assumed that they would be able to be resilient to outbreaks. But again, we saw the chronic shortage or deprioritization of health workforce investments, a lack of proactive and coordinated response, and especially poor adherence to infection prevention and control, which led to surging cases both in health workers as well as in the civilians, due to kind of this mixed messaging and risk communication we also saw in the UK. Also, we do see, I think, some lessons being learned there that even a dominance of UHC without health security pivots isn't enough. The UK has just recently, after a lot of push, finally started enhancing a lot of its border safety measures with increased testing upon arrival, quarantine and self-isolation, but there's still a long way to go in a more integrated and proactive testing and tracing system. And I think also here we have an increased recognition of the need for outbreak trained health workers, health security coordination that aligns all the way from WHO guidelines all the way down to the local health coordination, as well as this more integrated disease alert network that can help with surveillance and response. And finally, I think probably the most interesting examples from our paper came from those systems that were able to do a little bit of both. Invest in health security while also having a foundation for UHC. One standout region I think that we've all been looking to and can learn lessons from are countries across Southeast Asia. And while they're not a monolith, they have some really important shared lessons. I think strong experience from SARS in preparation for something like what we saw with COVID-19, as well as really strong investments in public health infrastructure, were actually coupled with comprehensive universal health coverage. These systems often have a very high degree of trust in at least their public health services and strong primary healthcare systems. And therefore, I think when we saw COVID-19 hit, some really innovative and interesting policies took place. We saw really proactive, strict, comprehensive public health measures that were met with very widespread compliance, unlike a lot of other countries like in the West and in other contexts that were not able to integrate these approaches. So things like mask wearing were not as contentious. We also saw really innovative approaches to data information sharing as well as resource allocation. Taiwan, for example, had this really interesting platform which was actually able to map out personal protective equipment and masks at a pharmacy to pharmacy level in real time. And I think what is also really interesting to note is the high degree of trust in UHC was able to foster not just trust in health services, but also a culture of surveillance and health-seeking behavior, so that these health security investments that were put on top were able to kind of have better outcomes than in other countries that had, good health security. So it really kind of is a testament that these things need layers, and investing in that kind of cross-cutting way is important. The story of the Indian state of Kerala is also a good example, where the state has a very extensive history of UHC and social protections, but also a very high degree of literacy and investments in education. This state is also really seen as one of the leading states in India to train high quality health workers. And therefore we were able to see really high engagement with and communication with communities, but also critically here, some really important investments in social protections. So we saw shelters made for stranded migrant workers, cooked meals for low-income communities, increased internet capacity for better access to information, and even advanced pensions for the elderly community. And finally, I think here too in our paper, after it was published, we were able to see that still these systems investing in a more cross-cutting way, there's still some gaps to be seen. Singapore, that did really well initially with the outbreak, actually overlooked many migrant communities and therefore faced a lot of clustered outbreaks down the line. And I think that's an important lesson for more integrated investments towards resilience and equity. And this more kind of touching on Negozi's points of synergistic investments in extensive tracing, decentralized primary healthcare centers, frontline health workers that are trained across multiple competencies, reduced privatization, and in integrated coordination across different health services. So just closing then with kind of our key recommendations, and we wanted this to kind of be focused more towards the issue of fragmented aid. So just a recap kind of on the context of where we are in many of our communities. At the community level, we see a huge issue with vulnerable populations, racial and ethnic minorities having large disparities when it comes to increased mortality and morbidity to COVID-19. We also have a lack of access to healthcare, which disrupted routine health services like HIV and maternal mortality. We saw that in Ebola, we're seeing it in COVID-19. We also have kind of an issue in many countries responding to multiple crises, and therefore a lack of political will towards prevention. And misaligned priorities with these siloed funding streams and poorly integrated governance. Critically here, I think for funding is to focus on funding at the community level with all stakeholders included. A colleague at Women in Global Health, Ann Keeling, pointed out to me that 0.17% of ODA funding goes towards gender equality, actually goes to LMIC-based organizations at the front line. And so I think it's a real call for donors to invest in frontline and community level organizations to leverage local expertise and solutions. And secondly, I think investing in more holistic and sustainable health systems approaches. We currently, our siloed health systems investment needs to kind of move along more of a spectrum, I think, towards a health for all vision with inclusive and diverse health services considered. And I think that means hitting important shifting in the way that we fund things through equitable partnerships, integrated health security and UHC components, and this push towards healthy populations and healthy societies to really consider the socioeconomic and political determinants of health that are often left out of any of those metrics. And I think I'll turn it back to Negozi for kind of the last two recommendations.
Thanks, Arush. Our third recommendation is really about funding, and I think an aid, and this is what a lot of our conversation, I think, is going to continue to focus on. So the first is, there has to be an internal prioritization of this one health system. And so one thing that aid entities can do is really incentivize domestic resources use mobilization. There's been analyses that show that if countries can raise at least 5% of GDP and put that towards health, that can go very far with protecting individuals and reducing their risk to daily health threats. But there will still be a gap, and overseas development aid must fill that. It's estimated that that gap is about $86 per capita per year. And what we've seen in multiple outbreaks and emergencies is that, we have a very reactive kind of health, global health body. And so we'll put money into something very quickly, expect very quick outcomes, but that's not really how a health system is built. And so these investments need to be long-term, and they also need to be core investments. Also, innovative health financing is very necessary. The multi-pronged approach is what some countries are doing to ensure that they can raise domestic funding for health. Thailand is a really good example. They have a three-pronged approach to fund patient care, health promotion, and population health services by using alcohol and tobacco taxes, as well as sub-district insurance schemes and government revenue. And Thailand has covered nearly 100% of their population. And also these different innovative health financing schemes should also include the private sector. We also recommend shifting aid to fund local organizations and support holistic programming. I think we'll talk a bit more about like vertical programming. And like I said earlier, the donors, they really do drive a lot of this segmentation in how we look at UHC and GHS. Next slide, please. Our fourth recommendation is to improve metrics for health system resilience. I mean, a lot of the assessments that, ranked countries like the US and the UK very high, they looked at, kind of technical infrastructure and expertise, but some of the very core metrics that we're seeing really matter, or core tenets of a health system and governance weren't really captured. So when we think about resilient health systems, so health systems that provide clinical services but are able to absorb shocks of outbreaks and epidemics, we think that resilience is an ability rather than just an outcome, and we need to identify metrics to reflect that. Also, we need new indices for preparedness. And so to avoid what we saw before with the Joint External Evaluation, the Global Health Security Index, indices have to be contextual, reflect power dynamics, include governance structures and status. And so we're hoping, I know that several of these assessment tools are being revised, and we're looking forward to seeing these recommendations considered. Also, a lot of the division of GHS and UHC comes down to how we measure it. Joint external evaluation can really be complemented with health system assessments such as the SARA, the Service Availability and Readiness Assessment. And there's many other data sets that are available at the subnational level that can really inform intelligence of what is happening around the country outside of the capital. So this is something that a lot of national public health institutes really support. And then underpinning the progress of UHC with global health and global health security by looking at health system strengthening indicators. Because as I said earlier, HSS isn't immediately UHC. It actually does have a lot of components of both GHS and UHC, and these indicators can be really helpful. And then finally, identifying gaps and measuring them. So we know that there are different systems that exist outside of health that very much impact health. For example, the amount of infrastructure, roads being built, that has to do with how many people are able to seek health care and to reach hospitals. And so donors need to be aware of these factors that influence health system resilience as well. Last slide. So just wanted to thank you all for listening to this presentation, and we're looking forward to the discussion ahead. Thank you.
Great. Thank you so much, Negozi and Arush. So now let's turn to Dr. Priscilla Bekwe, who's there in the Operations Center of the Nigeria Centers for Disease Control, to reflect on this issue and how also you've experienced financing both domestically from your national treasury or Ministry of Health and internationally. So over to you. Thanks.
Thank you very much. I'll thank the presenters for a very great summary. Clearly, this paper shows us very well that the COVID-19 actually has exposed the weaknesses in all health systems. But, even for countries that have had very good global health security infrastructure, or those who have very good universal health care coverage, and their health systems have been, and those whose health systems have been fortified. So we've had different results. And I think the core thing here really would be to reflect, each country to reflect on the progress they've made, embed good practice, draw lessons in order to build back better. And so this paper comes in quite timely in those conversations, both internal conversations and international conversations about building back better and preparing for the next epidemic, because these pandemics will come. And even when they don't come, countries like Nigeria already have endemic outbreaks. So drawing on lessons from these would always help us in managing our outbreaks and reducing both the mortality and morbidity that occur from these seasonal outbreaks, especially things like the Lassa fever and meningitis. So as I read through this paper, one of the things that was going through my mind was, it's so difficult to find out about cause and effect, and to find out what is the lever that makes the true difference. I think there are quite a few confounding factors that we need to consider as we discuss both across board and for every country to think about its own system. And there's a very clear thing that came out as I read through this paper, and that's the issue around the politics, the political economy, which we must not underestimate in any country. I think I'd like to refer us back to some of the initial definitions of public health that talks about the art and science of community health and organized efforts by the society to promote, protect, and restore health. So it's both a science and an art. And that art comes in with the political conversations that need to happen, where decision makers have to deal with different priorities. And so as strong as our systems are, whether it's universal coverage or the health, the global health security, we must always, as professionals, technocrats, be conversant with those political conversations that need to take place and guide the decision makers, especially those that have got the funding. I recall about, was it around 2000 or so, there was this movement around the new public health. That was around the time I was in training, and it became very clear that doing a needs assessment was not good enough, because many of the results of your needs assessment would sit on the shelf. You needed to know more around negotiation, the politics of making sure that these things are implemented. So going back to the conversation here and looking at the Nigerian experience, our coverage for universal health coverage is very low, less than 10%. But again, we've done a lot of work, having learned from the Ebola outbreak to, strengthen our national health security. And we have done this in several areas. As soon as the outbreak, as soon as the pandemic we were notified around the pandemic, we set up very great systems across our entry points, the ports of entry, international points of entry. Our laboratory systems were grossly, exponentially, improved and increased both in number, not only within the public sector, but also the private sector. And so we have tried to harness the strengths both within the public sector, the state, and the private sector. And our private sector businesses have come together as CARCOVID to support all aspects of our interventions, whether it's case management, trying to support ambulance, ventilators, building the treatment centers, doing what needs to be done. But one key caveat I would say here would be that to draw lessons from Ebola and such big outbreaks, and that would be to sustain the relationship, sustain the engagement in the long term. And this is something that NCDC has been thinking about for a while. Just before the outbreak, we have been contemplating around having an alliance for epidemic preparedness and response. So it's not just the cat COVID, it's something we've been thinking around. And it wasn't surprising when as soon as the outbreak, as soon as the first case was announced, even in our initial IAP, Incident Action Plan, the private sector, like the Dangote Foundation, was quick to, to respond and galvanize the organized private sector. And I must say, Nigeria's small businesses came strong as well in terms of providing, giving us small PPEs. I'm very delighted to say, even one of the days just before the lockdown, a very small business called up and said, "Oh, we're an electric organization. Can I bring extensions?" So there was a lot of that came through Nigeria. Now, coming back again to the universal coverage. So again, that's what I talk when I said something around the politics and the decision making. Nigeria showed its commitment to universal coverage through the National Health Act when it, through the Section 11, carved out what is called the Basic Healthcare Provision Fund, the 1% of the consolidated revenue in the country. And about 95% of this was slated between the primary health care and the health insurance scheme, and about 2.5% was given initially to NCDC towards public health emergencies. But we only had one allocation, and thereafter, it doesn't seem as if we're going to have further allocations. And so that's, that issue around, continuing to engage with the decision makers to see that all aspects of health and needs to be properly funded. And I will also say, so for example, even with this funding, okay, so
We can still hear you. Go ahead.
okay, good, thanks. So even with a small amount of funding that we got, the one-off funding we got, we used it quite well, as if we knew that the pandemic was going to come. This was in 2018, 2019, where some of that funding was used for the development of the establishment of public health emergency operation centers in 5 states. That's about 30% or so of Nigeria. 30, at least, 20% of states in Nigeria. We also deployed a SOMAS software, a surveillance outbreak response management system, and that has been crucial, vital in our response because we have real-time data. And to say, I feel proud as a Nigerian to be able to, see the data for Nigeria standing alongside every other country. And so I can say that today, because of the COVID response and the funding interjected, all states of the Federation, as I speak, now have had deployment of this SOMAS across the whole country, all the local governments. And this has been invaluable. And this is a Nigerian-grown concept that now many countries across the world are beginning to ask. And for this software, we have modules. It's very flexible to put in modules, both in modules in case management, port health, and every other aspect. So I will also say that in this conversation, I think this paper comes in quite timely, and the conversation we're having is quite, is apt for the moment, because we need to continue we support this idea of integration, and in terms of building robust capacities for global health securities into our comprehensive, universal health coverage systems. But we need to recommend, to improve strategies for communication and collaboration across institutions and national systems to try and unify our systems and our policies. It's very important that we're all at the table, not only in terms of developing, but also conducting assessments, simulation exercises, so that we are actually all talking to one another. We, of course, we support the conceptual framework of the WHO, trying to merge the universal health coverage and the global health security. We will really continue to advocate for funding, domestic funding, because currently much of the response seems to be, leaning on the donors. And of course, we have donor fatigue, but we have been efficient in the use of our funding and have tried to make every dollar and every naira go the extra mile, because we are custodians of this funding and we are accountable to the Nigerian people. Not only in doing this, we have also been transparent to, share the, things that have been donated and, have all been all on the website for of the presidential task force. So I'll conclude by saying that it's very important. This conversation is very important. I would like to continue to be a part of it and look for avenues to improve the synergy. There's a big gap that we did recognize, and that's the clinical care, which is not, like you rightly said in the IHR, it's not really a big, it's not quite mentioned, but you cannot do without the clinical care. You detect, there will always be some people who are ill, and we need to make sure that they are treated. Another large hole, a big gap, is a vulnerable group, which in Nigeria would be a lot of these poor people who are dependent on daily wage. And of course, it's difficult to enforce social distance or trying to do lockdowns when people are hungry. So it's not surprising that there is a kind of public outcry and difficulty in trying to maintain that type of policy. So I think I'd like to stop here for now. And my last word would be to continue to explore increase in domestic funding, deliberate increase in health security, until we come to a position where we have built our infrastructures and we're speaking to one another, and also continue to engage with the private sector in the long term and not have a knee-jerk reaction, but having a sustainable relationship with the private sector. Thank you.
Thank you, Dr. Bekwe. I think you've made so many really good points, and especially this last point, because the idea of universal health coverage is to pool public monies, right, including taxes paid by the private sector and all the rest, to finance care. But that care can happen anywhere. That care can happen in the private sector, can happen in the public sector. And the idea of public health and global health security is that it crosses the entire system, right? So I think the Nigerian example is so good on this, that you found ways to work with private providers very systematically, and really had a very important role to play in the detection of Ebola during 2013-14 outbreak in West Africa. So thanks for your interventions. Let's now, I also have some things to say on the issue of financing, but I'll come back at the end. But let's go to Kelly Saldana from the U.S. Agency for International Development to reflect on these issues. Thanks.
Great, thanks. And I might just pick up right there where you left off. I think this is a really important conversation. I'm really excited to be a part of it. I agree largely with everything that's been said at a conceptual level. I think it's really important, though, that we start thinking through what are the practical implications of these sorts of things. So from a USAID perspective, I'm sure most people are aware the funding that we have is fairly siloed into specific programs. And so when we think about working on health systems, we're thinking about what are those activities that cut across everything that we're trying to achieve at that more foundational level, and that are not as directly related to strengthening the specific aspects of the health system that you would strengthen if you were running a malaria program or a TB program. But what is it that works and cuts across? And so there's things like, the overall human resources system, because you're supplying human resources across the board, or making sure that public financing is, public financial management is in place, because you don't need that for each individual program. And so really trying to look through that, but really always keeping in mind the ultimate goals that we're trying to achieve. And so one of the things that I think that's contributed to sort of this problem is the fact that there is silos in the funding and there's silos in the programs, and even within UHC or health systems and within global health security. So health systems have been broken down into the building blocks, which have created a bit of silos amongst themselves. Global health security has been broken down into individual action packages. And all of this is too complex, too dynamic, and too interrelated to really break into those silos. So what we've been looking at USAID is thinking through where can we identify common goals that help to serve as that integrative force. And so using that as the entry point rather than building blocks or action packages. What we're looking at is, and I think has been covered, is an equity goal in vulnerable populations. If we're trying to make sure that marginalized populations or people who've been left out of health services are both receiving health services and participating in surveillance, what does that mean for where all these things come together? Similarly, if there is a quality aspect to how we're providing services, there's also a quality and a public health aspect to that. And we want to optimize then the resources that go towards those individual actions. So I think in the intersection between UHC and GHS, there's a couple of items that I would call out as needing particular focus. And so one is financing, which I think has been covered and Amanda's going to cover it later. And also has been mentioned is the surveillance and HMIS. Surveillance is only so good as long as it can be combined with knowledge of where do you have human resources to be able to respond, where do you have drugs and supplies. So you do need to have information about the resources within the system to combine with surveillance data to really be able to affect a response. I think two other areas that are a little bit more specific but offer opportunities is one on infection prevention and antimicrobial resistance. Infection prevention has to happen at the basic health facility, and it has to happen within the community and across. It's critical to global health security, and it's critical to providing individual health services. Similarly, I think there's a real opportunity with immunization, and especially the rollout of the COVID vaccine. Immunization, again, is another core area for global health security, but it is on the primary healthcare platform that we deliver immunization services. And I think there's a real opportunity available with the rollout of the COVID vaccine and the expectation that we'll have to roll this out annually or every couple of years, and not only to children under 5, but to the whole population, to really think about how do we build those platforms to support that vaccination. One of the other things that we think a lot about at USAID is what does health system resilience really mean? Is it just another word for a strong health system? And I think we've come to the conclusion that health systems resilience is really about building, I think as Arush and Negozi said, the capacity to take something that you've done to strengthen the health system in one area and apply it to other areas, or take something that you've learned in one area and apply it to other areas. So there's a series of capacities, adaptive or absorptive, adaptive, and transformative capacities. And just to provide a couple of examples, I think adaptive capacity or absorptive capacity is the ability to take intentional action to maintain stability. So we saw that countries were able to potentially leverage existing referral systems to direct COVID patients from one place to another to maintain the health system, or to use existing digital technologies to disseminate information. You also want to build adaptive capacity, which is the ability to make flexible adjustments in time. There's a great example from Indonesia where they had worked on having a human resources for health information system, and they were really able to put that work that they put into place prior to COVID to really transform that post-COVID, to really turn that into then a whole system to support health workers, to develop data dashboards and really effectively deploy their healthcare workers where they needed to go. Similarly, or finally, transformative capacity is the ability to make changes that can then, sort of be lasting and transform the health system over time. Some of the idea of building back better. So creating or implementing policies and structures that didn't exist prior. So there's some good examples coming out of Ghana and other countries about incorporating major campaigns so that hadn't been previously incorporated to better build the primary healthcare system. So adding seasonal malaria chemo prevention with tuberculosis and malnutrition screening, and then being able to better integrate other campaigns going forward. So those are just a couple of examples, but at the end of the day, if you have a resilient system that can adapt to things like a health worker shortage, or looking across at differences in how services are being delivered and at what effectiveness across the system, and redeploy resources. If you have a system that can do that when there's not a big pandemic going on, hopefully it has the capacity then to adapt when there is a pandemic going on. And I think a lot of this is about creating linkages throughout the health system. So you want to be able to link communities and the knowledge that's coming from communities with the government, with the national system, both for regular times, and also hopefully then to be able to transfer that capacity when there is an emergency or a pandemic. I think similarly, we want to build the structures to link and share resources between public sector and private sector delivery so that those systems are in place and can be called upon. So I think really we want to think less about prevention, detection, and response as separate and individual areas, but more as a continuum across, and thinking about the things that we want to put in place as part of a resilient health system that can then transfer over. Finally, I think critical to all of that is building on local knowledge and local ownership, and recognizing that just providing TA in one area has not been effective in building that capacity over. So I think we have provided a lot of TA in tuberculosis and HIV/AIDS about managing chronic care and chronic conditions. Very rarely do we see that applied towards diabetes or hypertension or other chronic conditions. Similarly, we provide TA in individual aspects at community health levels, or in specific entities of coordination that then doesn't seem to get translated into other aspects of coordination at the community level, which would be critical for both of these. So I think USAID has a new vision for health system strengthening that's coming out that sort of crystallizes a lot of these ideas in terms of sort of starting with outcomes and using that to integrate across services, and then recognizing some key themes in how we're doing our work, which is enabling transitions to local organizations, building these linkages, and then recognizing that there is a behavior change component across the board, not just on the part of clients, but also on the part of providers and health facility managers that really need to figure out how to adapt and adjust and change their behaviors in order to be able to respond. And I will stop there because I am looking forward to the discussion and want to make sure we get plenty of time for it.
Thank you, Kelly. So I'm just going to show, I wanted to back out a little bit to talk about the big picture. Can you see my presentation, or is it not here yet? Okay. So just to say, I mean, I think, what is this? Sorry. Okay. I think the first thing I want to say is that, this problem of prevention or public health versus universal health coverage is a theme that is one that has existed since the time that health services started. And if we look at financing, can you see the slides or not? Okay, sorry. Okay.
Yeah, we can see them.
Okay, well, anyhow, the point here is that domestic preventive spending in the wealthiest countries of the world is minimal, almost invisible. And so if you this is a graph that just shows us OECD spending on prevention over time as a as a share of government spending. It's less, it's about 0.2% of GDP. In a country like the United States, that spend has been dropping since the year 2000, okay? And if we look at domestic spending overall in low and middle income countries, we also see the problem that it's quite flat and very low over time. Of course, we know that in middle income countries, public spending on health is growing, but it's not anywhere near what is required even for a basic level of essential health services. So the point that was made about, I would put less emphasis on domestic revenue mobilization. That's the job of a finance minister, but from the global health side to say, the amount that we're spending in health versus other uses is still quite low and has been quite low for a very long time, okay? And so I think thinking about this extreme shock that we're all experiencing, it's a unique moment to speak to economic and finance authorities about the level of spending in global health and health in general and how we might act on it. But I would also say that 22 low-income countries are still spending less than $10 per capita through the public sector. So, we're not really talking about universal health coverage. We're talking about minimum levels of coverage and public health in some of the poorest countries of the world. For middle income countries, the situation is different, but I think it speaks to the need to set priorities based on how to maximize health. And we have to subject our prevention and global health security interventions to the same lens that we would subject our universal health care coverage interventions, or which means, how much health are we going to produce with this very limited amount of money that we have? And I think, when we look at what's happening with COVID-19, many countries had to establish extra budgetary funds to be able to do any kind of activity at all, which tells you that the existing health spending structures are not adequate to respond to the pandemic as it stands today. Just to show you the other question about aid. Now, this article is asking us to consider UHC, formerly known as health system strengthening, and global health security as emphases that we would, how do we combine these emphases or priorities? And I think the important thing to say here is that if we look historically at the uses of health aid, none of it is going to either of those two uses, okay? Not really. Health system strengthening and pandemic preparedness are such a small amount of total aid spending overall. So I guess the question for us is, we have these big priorities in aid spending that are genuinely very important health priorities. They are HIV/AIDS, they are tuberculosis, they are malaria, they are family planning and reproductive health, they are maternal, newborn, child, adolescent health care. So the question is, how do we make that body of spending work better for all of these uses, the ones that exist, and the need for pandemic preparedness and sort of a more integral approach to the way that we finance universal healthcare or health system spending. And again, just to say, even though we have, $35 billion where we are about now, this is from Tom Boyke's work with IHME, it sounds like a lot. It's nothing compared to the total amount of domestic spending. So this is, less than 10%, and much less than 10% in most countries, and less than 30% even in the most aid-dependent low-income countries. And then a final just reflection before I sort of turn to the implications is that most of what we call global health security financing is going towards immunization right now. And it's mostly funded by the Bill and Melinda Gates Foundation. So not governments, despite the fact that this is a kind of public good intervention. So I would say, that's where we are today. I'll stop sharing the screen, but that's sort of the big picture of financing. Neither global health security nor universal health coverage are major targets of external spending at this time. So I think the question is, how do we get this balance a little better? And also reflect that, looking at the financing of individual versus collective health, the way that institutions are set up also means that they are funded differently. So, the Nigeria CDC is different from the Ministry of Health and Family Welfare, is different from state level governments who technically have the responsibility to provide public health and prevention. So we have to look at all these financing flows and how these budget structures work together or do not work together. And that's without starting about discussing social protection and social assistance, which Arush and Negozi are also laying out on the table for us to consider as we think about response. I think the other point that I would make is that, okay, yes, also these financing flows are managed differently, but they also do different things. And some parts of the global health security agenda will not be part of a clinical care agenda, but some parts of the clinical care agenda will be part of global health security, and vice versa. There's some things that we would do in clinical care that have nothing to do with public health. But as you say, it's a continuum. And the question is, how do we pay providers or state governments or donors versus recipients? How do we structure those flows so that it works better for that continuum of response? And I don't think any country has solved this as well as they might. And I do think what the paper really does speak to is the need to consider this in a more systematic way. And I put a lot of attention on the financing because I think it's a lever that we have, especially as external people, to talk about sort of how we might structure that. One idea that we've talked about in the past is, within our disease-specific programs that are the trademark of U.S. assistance, for example, is it possible to make 20% of those funds government-to-government funds against some measurable progress in some of these cross-cutting functions or areas that Kelly has mentioned, right? Data and surveillance, lab strengthening, et cetera, where we would look at, how well it operates all together. Another possibility, and I think the other thing to say is that we have an opportunity with this terrible crisis to focus more explicitly on prevention and global health security as a use of monies. Now, again, if we raise money because if it's useful to raise money, as some have said, let's say from a defense budget, so that it's not ODA, because as someone has also said, this is not just an aid issue. This isn't all, this is a major public policy issue just in general. So say we used our Department of Defense money, for example, to work on health security. The issue, maybe that's a good way to actually build the pool of resources that are available for prevention and public health. But I think we also have to say, however that is raised, we also have to think about deploying it in a way that doesn't create more problems. Deploying monies in a way that helps with the broad agenda of public health prevention, clinical care, and beyond, rather than creating another silo where things don't work for each other. So that's all food for thought. So now I'm going to turn back to our panelists to discuss further. We've talked about, let's see, what is on my list. Now, first, maybe I'll pause and say, do you, Negozi and Arush, want to respond to what the discussants have mentioned? And then I'll come back at you with some specific questions, both from the audience and ourselves.
Yeah, no, thank you. I'll just quickly jump in and just note that I think one thing that I particularly appreciated about both panelists is kind of the point around needing to invest in kind of more cross-cutting functions as a true marker of where we're going to go forward. I like Kelly's points about these three versions of kind of resilience indicators: absorptive, adaptive, and I think she mentioned something else. And I really like that model. I think that's exactly where the funding needs to be going. And I think something that Priscilla mentioned, which is also just important to really highlight, is the fact that in countries like Nigeria that have done a really good job of responding to other infectious disease outbreaks, there's a lot of lessons to be learned. And I think that speaks to Kelly's point about, I think especially that absorptive resilience indicator, that you can repurpose and pull out lessons. But if our technical assistance funding is not thinking of it in that way and looking at funding in that resilience ability, we will fail where we didn't need to, and that funding can get stretched further. So I think that's a really big point. And the last thing I'll just mention, and something we can talk about more also as a important tool for financing, is also pooled procurement. It's something that I didn't really get to talk about a lot in the paper, but is also probably an interesting way to consider. One of the hats that I wear is working at PAHO WHO on our pooled procurement medicine for access to medicines and supplies. And I think, this both leverages the technical cooperation that multilateral organizations like WHO can provide, but it also has really good abilities in maintaining those routine health services that often get pushed to the back during an outbreak, while getting also funding for the actual response to COVID-19. So we've been able to cut down costs by pooling together demand for HIV and hepatitis medications by up to 97%, while still making sure that funding is available for both emergency response and these routine health services. So I think pooled procurement mechanisms are an important tool to kind of be a bit more cross-cutting in their very nature of being joint and pulling together from different areas. I think it's a good way to almost think about financing at a systems level. So just kind of positing that as well.
We'll have a separate event on that, I guess.
Yeah, I'll just add in here. I really appreciated Dr. Bikwe's and Kelly's presentation, and yours as well, Amanda, because what I think it's like, if we would have seen Kelly's first and then Dr. Bikwe's, it's a lot of the things that Kelly mentioned. I think Dr. Bikwe really illustrated when she spoke about Nigeria. So like, when she talked about SORMAS and how it has been repurposed in many ways. You know, I mean, SORMAS is innovative, but it also was already functioning, you know, before COVID-19, and they've scaled it up even more to now every state in Nigeria is using SORMAS and is trained on that. And I think that's just really important that, you know, this, as we all know, the systems that are there now, those are the same systems that we're going to have when we have these massive shocks. And so I think, you know, when we're thinking about what it looks like, I mean, I really appreciated Kelly's nuance of, you know, that there are silos within the silos, because yeah, it sounds really good to like, let's just break up global health security in UHC and then put it back together in some magical way. But it's more than that. I think that when we're just thinking about a more straightforward way of going is how can we strengthen those areas? And I feel really relieved that USAID is already looking at, you know, beyond health information systems, specifically IPC and workforce capacity. I think, you know, we saw that in poor countries, low and middle income countries, as well as, you know, more wealthy countries. You know, healthcare workers were not protected. There wasn't this consideration of surge capacity. It was an assumption that what is there can take care of it. And you know, pulling workforce capacity, workforce development, surge capacity, as well as health information systems out and prioritizing those aspects of the health system to really invest in, so they're operating optimally before we get into an outbreak, epidemic, or pandemic situation. That's the lesson that I really pulled out of both of those presentations. And then I think finally about your presentation, Amanda, you know, being so involved in global health security, it does seem like it's this world that is like flushed with funds. And I think it was really helpful to see that actually when you look at ODA, it's still microscopic. And so I think you're absolutely right, looking at where, you know, that cross-cutting funding can be applied through these existing programs like immunization and maternal health and nutrition and all of these really, you know, bedrock programs of health systems. That is an important way forward. Thanks.
Great, thanks. So I see Dr. Priscilla would like to come back in. I'm just going to mention two questions that came in. So, and you can maybe choose to respond to some of them, Priscilla, and then I'll go back to you, Kelly. So one question is, many of the positive factors that you've identified in Southeast Asia and Kerala address social determinants of health and social protection systems and not healthcare. Surely this implies more health aid should go to those areas, right? So we're in our little health bubble. We know the other things are important, but we're still not talking about that other part. And, you know, in a situation of scarce resources, which goes the farthest, question mark. And then someone has asked, should there be a global fund for global health security? The White House is now developing options for an enduring international catalytic financing mechanism for global health security. What do you advise? So first to you, Dr. Priscilla, what's your view? What should the White House do? And then what about the social determinants of health?
So I'll start with the comments I had in mind, and maybe we'll be able to say something around those the questions that have just been raised. So I wanted, first of all, when I saw your slides around the global spend by ODA on health system strengthening and global health security, it's alarming. It's alarmingly low. And that calls to mind the fact that there's a clarion call here for all spending, that whatever funds countries have from these, we really need to strive for efficiency in the use of those funds, because these funds are actually very small in relation to the need. A second thing that struck me, as I was listening to the conversation around the possibility of using funds from the military to push for health security, is I recall I think there's a need to think around the impact assessment of some of our public health policy. So if this is a way to go, we need to kind of think around an impact assessment before this type of policies are pushed through, because they may have implications. The intention might be great, but some of the outcomes might be unintended. So we need that to be helpful to think around an impact assessment of those policies, public health policies, before we push them through. I quite like the idea around the pooled procurement, which I think would help in terms of synergy. It was very easy for organizations such as UNICEF or WHO to go to the global platform to make buy. Even African CDC did pool procurement for Africa, and we did enjoy some of those synergies and gains that came through that process. I'd like to also say that in Nigeria, some of the things that we've already started doing is actually not, trying to harness and build on the gains that we have. We're beginning to think around network, looking at public health networks, networks of our public health laboratory, network of the public health EOCs, trying to make them efficient. The inroads we have made in infection prevention control, over 45,000 healthcare workers have been trained to date. So we are trying to put in systems. We really don't want a hit and run approach. We actually want to put in a system where, for example, in the state health system, you have focal people and committees on infection control. So we're actually, this conversation with the clinical team would have taken more than 10 years to even get there. But the COVID has made it faster, and we have seen the commonalities in this. And one more thought, the Global Fund, through this, in our procurement and in the way we have reacted in Nigeria, we've had to use the Global Fund has helped us to reprogram some of the funds in country for ATM, for AIDS, malaria, and tuberculosis. And we have used the synergy of the gene expert machines that's already being used in TB and HIV to do testing. So, of course, not disenfranchising the programs themselves, but we have kind of leveraged on these programs. So I think it's something good to look at. And I think the Global Fund, perhaps replenishment and considering health security would be a good way to go. Thank you.
Okay, Kelly, final words. We're 3 minutes from the end, so.
Okay, well, I'm gonna maybe take that 3 minutes to circle back to the topic of measurement as sort of both a symptom to and solution of or symptom of and solution to the problem. So there's this old adage that what gets measured gets done. And I think if you take a step back, I think measurement is what contributes to a lot of the siloing. So we want very direct impact on morbidity and mortality outcome indicators. Within health systems, we have a lot of people say you can't measure health systems, but I always say there's too many indicators. They're all very specific to individual building blocks. And so if you're trying to seek results, you're programming in that. I think you have a similar issue with the JEE. And so when we start talking about measuring something like resilience, which is often measured after the fact, because you can see whether or not a health system was resilient or not, but it's hard to know beforehand whether or not those capacities exist. So, I think a couple of ideas that might help to better synergize the existing aid that we have is if there are a set of common or cross-cutting measurements that we expect in addition to mortality outcomes of the existing programs, might that push them to think about and how their activities have more of a cross-cutting impact. Similarly, we at USAID have been developing a measurement tool that's based on sort of perceptions of processes. And so with this underlying idea that, the basis of quality improvement is everything is based on how you're improving an individual process. But if you start looking at across society, what do people think of how well these processes function, you can get to a little bit more of an in-depth analysis about whether or not you may think objectively something exists, but if no one believes it exists, it's sort of like the tree falling in the woods. Like, does it really, right? If nobody buys into it. And so and it's easier to measure. So can we get at a deeper understanding of aspects that go into a lot of the things that would be a process that would create then a resilient health system, and use that over time to get to a measurement that would have more of a specific policy prescription that is a little bit more subject and open to what people in countries, would have to get together and figure out themselves, rather than, sort of a more direct impact, which leads to silos. So food for thought.
Okay, so thank you everyone for this. We have to wrap up now. I just want to make a final reflection on, I actually think the problem is the opposite, that we focused it too much on processes and structures and not enough on performance of how things work. Take, for example, let me give you another. The Tom Frieden just came out with the idea of the 717 framework, that we would be able to, detect a novel pathogen within 7 days, turn around and investigate and, stop it at source within, the next week or something like that. Or like Richard Hatchett from CEPI has come out and said, for the next round, we should actually have 100 days between the genetic sequencing of a new pathogen and a new vaccine. So I think what I would say is there is a need to focus on how well these systems perform, not just whether the system exists. So, even let's say data, right? How complete is mortality data? How rapidly are deaths reported? And do we have cause of death? Like, we could measure accuracy of systems in real time in a better way. So that allows us to focus on the function, but also on how well it does. I suspect, but I guess the other main thing is that there's not any consensus within the field on what preparedness measures are really going to look like going forward, right? We're seeing as COVID-19 evolves, increasing calls for the ability to do genomic surveillance across populations or across representative samples all over the world. Is that our new standard of preparedness? So I think there is a need to come together and say, well, what are the minimum functions that we need to see in this space of global health security, prevention, preparedness, and then also discuss that intersection with health systems. Anyhow, so there's a lot more to do here as the bottom line, and more conversation to be had. I will take you up on the idea of talking about procurement more, because pooled procurement is certainly a hot topic these days, and the incentives to participate in pools, of course, also a hot topic when we look at what is happening with COVAX. So just to say thank you so much for all of you for joining and for your great ideas and new directions at USAID as well. And stay tuned for more discussion of these. So take care, everyone. Bye.
Thank you.
Thank you.